late Professor R.P. Tandon.
Sure, ma'am. Just now.
हाँ
हो गया.
Great honor to introduce Dr. R.P. Tandon. Though personally, I'm not, very much. I have never met him actually.
Show the slide. Premlata, please show the slide.
Yeah, Premlata, will you please go to slide of Dr. Tandon?
Premlata, please.
So
please show the introduction slide. Okay, in the meantime, you can keep
I can
reading.
start. Yeah, sure, ma'am. So, Dr. Rajeshwar Prasad Tandon is no longer with us. He was one of the most prominent members of our fraternity. Those of us who had the privilege of knowing him would fondly remember him as a distinguished ophthalmologist and a wonderful human being. He was very knowledgeable and had immense wisdom. If there was one trait that defined him, it was his quest for knowledge. He was a voracious reader and he imbibed everything that he read. He could talk on any subject from ophthalmology to oceanology, from philosophy to politics, from science to economics, and from history to the latest gossip. He was a great communicator, and once he got onto a topic, you could not but be charmed by his clarity of vision and oratory skill. He had a natural gleam in his eyes and a mesmerizing smile. Dr. Tandon had his early education at the St. Michael School, Patna. He did his MBBS from the Prince of Wales Medical College, Patna, in 1954 and MS in 1957 from the same college. He then joined the Bihar Health Services and was posted at Bodh Gaya. He left for London in early 1959 and did DO, RCS and RCP, followed by FRCS in 1964. He came back to India in 1965 and joined Rajendra Medical College, Ranchi, and worked there for the next 10 years. Dr. Tandon left government service in 1975 and went into full-time private practice at Ranchi. With the liberalization of the economy, he was quick to grab the opportunity to upgrade his clinic with the latest equipment and technology. He was very popular among his colleagues. To them, he was just Tandon. He was clinician and surgeon par excellence. His clinical knowledge and wisdom was immense, and most of the who and who of Ranchi flocked to him for advice and treatment. His clientele also came from all the nearby areas of Ranchi. He was one of the founding members of the Academic Medical Forum. He was its founder secretary, wrote the constitution, and later became its president. AMF honored him in 2000 as the most outstanding ophthalmologist of Ranchi for his leadership in leading the forum to its present position, and above all for his being the fine model of a cultured human being. He was president Bihar Ophthalmological Society during 1989 to 90. Jharkhand Ophthalmological Society honored him with Lifetime Achievement Award in 2006. He commanded a versatile personality during his lifetime. He authored many books on varied subjects. For example, Successful Man, Transformation to Love, Mind, The Karmic Laws, etc. To name a few. Apart from academic forums and societies, he was also a member of Sri Satya Seva Trust and Sri Satya Organization. Dr. R.P. Tandon left for his heavenly award on 3rd December 2011. He leaves behind a great legacy. His wife, Mrs. Saroj Tandon, his 4 daughters and their families are doing well, and we are proud to have one of his daughters, Dr. Dolly Tandon, as an active member of the Jharkhand Ophthalmological Society. So it's thank you very much. Now, Dr. Bharti Kashyap, would you like to proceed?
Over to Dr. Dolly Tandon. Dr. Dolly Tandon.
Yes, thank you, Dr. Bharti, Dr. Anindya. And it is my proud privilege to introduce Dr. Professor Vishali Gupta for the Dr. R.P. Tandon Oration Award. Dr. Professor Vishali Gupta is a very well-known name in our ophthalmological fraternity and presently Chief of VR at PGI Chandigarh. She is holding and also previously held many important and prestigious posts like President, International Uveitis Study Group, Vice President, Vitreoretina Society of India, Past President, Uveitis Society of India, Member Scientific and Bylaws Committee, Macular Society, Chair Program Committee, ARVO. She has, to her credit, many PubMed indexed publications, 416, over 16,000 citations, and 68 high index. She has presented 1,087 lectures and international lectures being 568. She has to her credit, she is to her credit one of the top 2% world scientists in Stanford ranking since the last 6 years. She has edited 6 books and book chapters 87. She has 2 US patents to her credit. She has been awarded with P. Shiva Reddy by AIOS, Colonel Rangachari by AIOS, Steph Foster Oration during ARVO, Shyamala Bhaskar by LVEP, G. Venkatswamy Endowment Lecture by Uveitis Society of India, Alumni Oration and awarded by Shankar Netralaya, Sadguru Oration by Sadguru Netra Chikatsalaya Chitrakoot. She is among the top 100 most influential ophthalmologists in the Asia Pacific from 2022 onwards. Thank you, Dr. Vishali Gupta. Eager to hear about the road less traveled.
Thank you very much, Dr. Dolly. Thank you very much, Dr. Bharti and the Jharkhand Ophthalmological Society for giving me an opportunity and honor to remember Dr. Tandon. So the topic that I have chosen for today is the road less traveled. Let me begin my journey on this road. It was year 1995. I had just joined ophthalmology, my first year resident at PGI Chandigarh. So there is a report of about 5 cases from India where the eyes were removed because the diagnosis of TB could not be made, and a beautiful publication by Dr. Jyotirmay Biswas showing the histopathology of the eye. Now, as a resident, I thought like TB has a treatment, and why are these ophthalmologists enucleating the eye for TB? So this was something which I took up as a challenge. So that was my first time where I learned that TB is causing blindness because we won't recognize, we won't even treat ocular TB because we believed it did not exist. So this is the beginning of my journey, and the road that I took was less traveled, because the more traveled road is on the left, the cataract surgery, and the less traveled is on the right, that is the uveitis. While eradicating blindness due to cataract is, I would say, easy, but it's easy, honestly. Whereas the blindness due to uveitis is a tough task, and it's not very popular theme. What exactly is blindness? Blindness is not a disease. Blindness, if you go back to Picasso's work, for some of you who love art, there was a dark period in Picasso's life, and where he painted all the beggars, street urchins, old, frail, and blind. Because once you make a person, I'm not saying you make a person blind, once a person is blind due to something which you fail to treat, the blindness is not a disease. It brings about the marginalization of that person in the entire society. So how do we diagnose ocular TB? And this is the picture taken of Robert Koch, which was, almost 100 years ago, 1905 in Berlin, when he discovered treatment for TB. So this is him just coming out of after receiving the Nobel Prize in Medicine. What were we doing in ophthalmology 100 years later? Not even treating the disease, which was so very, very treatable. So I was a first-year resident, as I told you, and I had a mentor, Professor Amod Gupta, blessed to have him in my life. And this is one of my favorite pictures in medicine. This is called the doctor. Now, if you look at this picture very carefully, this is the picture belonging to a child suffering from tuberculosis. If you look at the doctor is thinking, like, what can I do for this child? There is a light coming from the window, which means that he has been awake throughout the night looking for the treatment. The parents are there, but they are in the background. They are not the ones who are primarily concerned. The primary concern is the doctor. And even the medicines are on the side of the doctor because he's making sure that he gives it himself. So we thought, how can we diagnose ocular TB so that we don't have to enucleate the eye and prevent blindness? That was the time Professor Gupta gave me an idea that there is now PCR available. Let's start doing PCR from the intraocular fluid. Sure enough, we started doing it. I was very excited, and this is me way back in 1999. I presented my work about PCR positive for tuberculosis in some of the patients with uveitis. Well, this was the meeting, and guess what? Lot of criticism about how can we use PCR for ocular TB. And this is what I want to tell our younger colleagues out there, that whenever you say something, you will be thrown stones at. But what do you do? When people throw stones at you, you turn them into milestones. Let the senior people not discourage you if you find something new. For me, it was, they said, oh, TB does not exist in the eye, so PCR is false positive. Somebody from a very premier institute, a big professor, said, oh, we sent water for PCR testing and it was positive. Should it discourage you? No. You follow your path. Today, I can say PCR was truly not a magic, but it gave us a tool with which we could define various phenotypes, and these are granulomatous uveitis, hypopyon, snow banking, vasculitis, tuberculomas, and serpiginous-like choroiditis. Now, when we look at these phenotypes, we understand that they are TB. they need anti-TB treatment, and when we add anti-TB treatment, the recurrences rates would be reduced dramatically. Before we said that TB could cause serpiginous-like choroiditis, generally serpiginous choroiditis was being treated with steroids and immunosuppressive drugs and had 100% recurrence. So people were using almost 3 immunosuppressive drugs to control it, but with our discovery or with our introduction of this term, adding anti-TB drugs, no need for immunosuppression, and we could achieve remission in almost 90% of the cases. Multiple publications came that just addition of anti-TB helps in reducing the recurrences in more than 80% of the patients. And well, it did take us about 100 years to start treating ocular TB, but we finally reached there where we made ocular TB being recognized and the need for treatment. This is the year 2015 when my mentor, Professor Amod Gupta, kind of superannuated, and this is the picture just taken that day. What had we achieved till then? Till 2015, we all understood that TB is a very well recognized form of extrapulmonary disease. We all thought that we have done so much work, so everybody would recognize, and even the DOTS program and all should be able to give anti-TB drugs to our patients with ocular TB. However, that was not true. Ocular TB till 2015 was not even considered as a part of extrapulmonary TB by authorities. And this shocking revelation came to me. There was a roundtable conference with an effort to incorporate ocular TB as national TB control program. And we got criticized that ocular TB is not seen worldwide. There are only few centers in India which are seeing and reported, and it just does not happen. So came the policy document from the Government of India in 2007 about Index TB guidelines for extrapulmonary TB, and ocular TB was not a part of it, which means whatever we had been saying, our own government did not believe in that, because some people up there thought that ocular TB is not a problem. Well, what do we do? So that was the second stone which I took personally, and I said, okay, we will show that ocular TB is not a problem of PGI Chandigarh or Shankar Nethralaya Chennai. It's a problem of the entire world. We collected 4 people, and these are my collaborators: Carlos Pevesio from MUFI London, Rupesh from Singapore, and Kwan is from Stanford. We actually met for the first time at an airport lounge. We said we have to do a multicentric study. I was told, you cannot do multicentric trial without funding, so drop the idea and don't make a fool of yourself. Don't listen. If you're convinced with something, go ahead. We did start working on the pure goodwill gesture of our collaborators, 25 countries, 900 patients, and we just made a motto: together towards tomorrow. We had no funding, we had no financial banking. It was just a goodwill gesture of experts who did the data entry, our youngsters who worked very hard. And together we came with 27 publications on ocular TB, which was the first multicentric, or the rather only multicentric study of ocular TB. The next is, now how do we convince our ID specialists that they should give ATT to our patients? So we decided to have a consensus document, and we were privileged that by this time, ocular TB study group was joined by all major international society backing us up, which included IOIS, IUSG, and Foster. We did a very intense consensus meeting, which was held in Chandigarh, and suddenly there were a lot of people who were, joined the bandwagon, and I was no longer alone in my mission. And we came up with 2 publications in ophthalmology giving the guidelines to the internist as to how to and when to initiate anti-tuberculosis therapy. Fine. We did come up with this, and for me, this was the personal win, winning the mission when the standard treatment workflows of India and the ICMR guidelines included ocular TB as a part, recognized it as extrapulmonary TB. For me, that was kind of a very important step. So we did come up with the consensus, a multicentric consensus, but then the next stone came. Well, you have given good guidelines, but it's very difficult to remember those guidelines in day-to-day practice. So we came up with the next step, which is the calculator. Very simple. You just enter the age, name, gender, and country. It automatically shows you the endemicity, that it is from endemic country. You enter the phenotype, and we just took 3 tests, Monteus, interferon, and chest. And we tell the calculator, you calculate what is the risk. And it gives you as an app that there is very high probability amongst the experts to consider anti-TB drugs. It's as simple as that. Whenever in doubt, you can ask the calculator that what would the world experts do in my situation, and the calculator will give you an answer that whether they will give anti-TB treatment or not. The treatment CORDS calculator was available. Stones continued, criticism continued coming from the premier institutes saying that COTS recommends overtreatment. Not really. COTS does not recommend overtreatment. So we really validated our calculator based on the criticism, and we have 2 publications now. One is the in JAMA Ophthalmology about this COTS calculator being used all over the world, validating it. And second is by Dr. Jyotirmay Biswas about validating this calculator in the Indian population and showing that it works very well without overdiagnosing. This brings me to a kind of an end of my journey in ocular TB, which started in year 1999. Actually, near 1995, when I read a publication that why the eyes were being enucleated from ocular TB, reaching a point where hopefully we will be able to recognize these eyes in time and not make anybody blind from something as simple as ocular TB, because this is our problem. We have to find an answer. And it was wonderful because in year 1999, which was the first meeting of Uveitis Society of India, I had received the criticism about floating this idea. And this is year 2022 when I got G. Venkataswamy Oration on the same topic. So I think it's important that if you believe in something, just persist with it. Of course, the work is, these collaborations and all, they do require a lot of people who help you. And this is my favorite slide, that tree's beauty lies in its branches. That's fine. My branches are my students, but the strength is in roots. And you never forget the roots. You never forget the people who taught you. You never forget the people who were with you when you had an idea without the world experts backing you up, because those are the people who are really important. Once you have done something, everybody wants to know your story. But the people who listen to your story when you are nothing, They are the people you should always remember in your life. This is my lovely department. I'm very grateful to my teachers and my colleagues and my students. We run a beautiful MCH program only one in the country right now. And it's really nice to have these youngsters with us all the time. People who have been with us for years together, like the support. A big thanks to them and a big thanks to my lovely family, my husband and my daughter, for this difficult journey that I took. All these people made sure that I was not alone in this journey and they were always around me. With this, I would once again like to thank Jharkhand Ophthalmology Society for giving me this honor and opportunity to speak to all of you on a Sunday afternoon. Thank you very much.
Guest faculty talk of Dr. Rajesh R. Dr. Seema has joined our secretary, ex-secretary Dr. Subrato Mitra is there. Welcome, Dr. Subrato. You have to say a few words before Dr. Malaya Verma's vote of thanks. Because you are since morning and I can see you.
I am since.
Vibhuti Bhushan, they have to say a few words before vote of thanks. So Vibhuti is also there, Seema is there. Seema could not come because of the GTR fast. So please take up coordinators, please take up Dr. Rajesh R. Dr. Rajesh, are you here?
Yes, ma'am, he is here. Yes, sir.
Okay.
Dr. Rajesh, you can start your presentation.
No, have you done his introduction?
No.
Ma'am, we have already dealt. We have already introduced him, ma'am.
Okay, he's from RP Center, AIMS, New Delhi.
Yes, ma'am. Yes, ma'am.
And he has done his fellowship from
Shankara
Netral. And he's the right hand of the most senior faculty of retina.
Dr. Mahesh P. Sangam.
Dr. Mahesh P. Sanmugam.
Yes, ma'am.
Okay, shall I start sharing my slide, ma'am?
Yes, please. Yes, please.
So can you see my slides, sir?
Yes, it is visible and you're audible too.
Yeah. Thank you. Thank you, Dr. Bharti ma'am, for this opportunity. So I'll be presenting in one of the least, told about problem. So we were confronted upon a few patients who had an accelerated diabetic retinopathy, and we were fumbled upon what would be the probable cause. So since we started searching for these lesions, what might be the reasons for aggravating such conditions, we had a few of our own patients. I'll just go through the history of some of them. So when I looked into how would I divide these patients, based upon certain systemic factors, which comorbidities which the patient had, or the ocular features which I had presented with, along with diabetic retinopathy, and some masquerades, which since we are an oncology center, we do get some masquerades which can manifest as diabetic retinopathy. So these are the three broad classification on which we see patients who had previously had a very subtle amount of diabetic retinopathy, and they suddenly had some, increased accelerated outgrowth. So getting one by one, so let us look into the hematologic dysplasia. So I'll just start with one of my patients, 61-year-old gentleman who had presented with us with a diminution of vision in the right eye for 20 days. He was a known diabetic and hypertensive with fair metabolic control. Not to mention his vision acuity was also quite okay. The right eye had 612 N6 and the left eye is about 66 N6. He has dyslipidemia also. He had received some amount of anti-VEGF elsewhere because the right eye had center involving diabetic macular edema. So this is what he presented with. You can see the color photos and the OCT. OCT shows cystoid macular edema in both the eyes, a little bit left more than the right. So what we decided, since he had already received anti-VEGF, we thought let us give him the benefit of Osidex, since it was just introduced at that point of time. And we saw whether it might give some additional benefit as compared to anti-VEGF. This is about, we could see that about 10 to 20% of the reduction of CMT had occurred in the right eye as well as in the left eye also. So looking at this within the matter of 2 to 3 weeks, we felt that the patient might respond better, and we continued monitoring him. But at 4th week, we did had some amount of laser and followed him up. But for our dismay, both the eyes at around 4 to 6 weeks post focal laser started developing the edema. The edema had regained, and now it was much more than what it was to present with. So, I mean, the patient was most probably frustrated because he had already seen multiple doctors and it had presented to us. So he was lost for follow-up. Maybe again he went for some amount of second opinion, and then he came back after 10 months later. And 10 months, it was even more dismal. The vision acuity in the right eye had now deteriorated to 3/16 and 36, and he had some amount of cataract, maybe because of the Osidex which we had given. And post that, in that 10 months, he had some other injections elsewhere. And the left eye was a bit more maintained. It had 612 with N8. So look at the amount of CMT in this patient. Right eye, it's completely ballooned up, as well as in the left eye also. And since the cataract had progressed in the right eye, that's why the vision was much worse. So we took a dive into the systemic examination. Systemic profile was very much within acceptable limits. What I mean by that, HbA1c and hypertension. But the one thing which was noticeable was his platelets. It was about 60,000. And then we diagnosed this patient as ITP with hypertension and moderate NPDR with status post multiple injection and laser. So ITP was the main cause of this recurrent edema, which was not readily getting cured or responding to the standard treatment, that is anti-VEGFs and Osidex. So the patient came back after all these investigations and the physician opinion. Now the platelet was 30,000, and you can see it is even more ballooned up. So only thing that we need, for what we noted was, when we look back into the history and all his investigation and OCT, and we correlated his blood examination, it was seen that whenever the macular edema fluctuated according to the platelet, so the platelet was less, the macular edema was more, and the hemorrhages were more. And when the platelets were better, the hemorrhages were, and the edema was much better. So we started the patient to go on with systemic steroid. We can see how once the ITP was under control with the systemic steroids, with 175,000 of the platelets, the edema was getting better without any intravitreal injections or any other intervention, ophthalmic intervention. So that's the one thing. So whenever we have a patient who has blood dysplasias, not only this, even in patients we have CML. So these patients also present with these cystoid macular edemas and hemorrhages, which may not be correlating with this systemic control of sugars and hypertension. The second well-known association with diabetic retinopathy is nephropathy, because diabetes do cause chronic renal disease also. So this is one of the classic patients where patient presents to us, we have treated, it was stable, quite stable, sugars are unstable, but once the patient comes with the deteriorating renal parameters because of whatever the reason, we can see that the edema is progressing. So second of the causes in which there is an accelerated diabetic retinopathy changes despite the sugars being under control is, if there's any worsening of the hypertension or nephropathy, we can definitely correlate with the worsening eye conditions also. Third is, if a patient has undergone a cataract surgery, we know that if a patient has a center involving diabetic macular edema and the patient undergoes a cataract surgery, there's definitely progression of the involvement and further deterioration of the edema status post cataract surgery. Even to that extent that patients who were well treated and were completely stable at the time of cataract surgery, 20% of these patients who had resolved diabetic macular edema post cataract surgery can develop. But in this patient, you can see that the minimal amount of CME which was there post cataract surgery is developed into what we call as the cystoid macular edema and some amount of NSD also. So these patients are usual form of treatment of IVTA or DEX implant can definitely resolve the macular edema and keep them stable. Patient who has hypertension do have retinal vein occlusions, either TRVOs or BRVOs, even to the extent of CRVOs also. So a patient who has diabetic retinopathy who suddenly develops increased macular edema or neurosensory detachment, we need to look closely, because certain small tributary retinal vein occlusions can cause quite exacerbation of the macular edema, which may not be completely stable or mainly responding to the regular anti-VEGF that we give to these patients. Coexisting macroenzymes. So what we look at is the AV crossings, where some of these patients do develop macroenzymes, and macroenzymes can bleed at all levels, whether it's epiretinal or preretinal, or even to the extent subretinal or intraretinal. So any of these levels, the hemorrhage might proceed and cause concomitant macular edema. So a patient who is quite stable, what we trivially look at as mini or micro or mini aneurysms might enlarge to macroaneurysms, and that can cause bleeding and development of macular edema. So we need to keep a close follow-up of these patients. If such a thing is noted, then we can laser, or most of them they self-involute, but if we laser, the edema also regresses for a period of time. So another concept which we came about a few years back is when most of these diabetic macular edema patients who have some microaneurysms are treated with anti-VEGF or DEX implant, they do respond beautifully. But what we looked at is some patients, despite the injection, you can see this is all the upper OCDs are pre-injection and the lower bottom OCDs are the post-injection various, whether it's anti-VEGF or DEX implant. You can see the response is very, very minimal, marginal, not even 10% of the initial CMT that we look at. So when we look very closely, what we could see is enlarge it. We had these aneurysms which are a little bit more than the microaneurysms which are typically noted in diabetic retinopathy. So this we termed at that point of a time as mini aneurysms. These time, I mean, over a period of time, they have been labeled by various groups in various terminologies, telcaps, or PEVAX and other things. Nomenclature has been given. So telcaps is what has been noted recently. So these, what we call a little bit more than microaneurysms, do not respond very, like any other usual mini-aneurysms or patient with diabetic retinopathy. These patients do respond beautifully to laser. So if at all we note these patients which are very clinically seen as well as in OCT can be picked up, and once we do laser, so they resolve very wonderfully. The edema goes down. Rather than only relying on anti-VEGFs or dexamethasone implants or tricot, we need to laser these patients. So focal laser is always added armamentarium which we have. We should never forget it. So some patients do have what we call as a premacular bursa. So the PVD is not there. There is an empty space between the posterior hyaloid and the macula. So these patients are known to not to respond to the regular treatment. That is, once we give anti-VEGF, the reason behind is these empty bursa spaces prevent or does not allow the pharmacological agent to reach the retinal surface and thereby causing the resistance of edema. So if such a thing is noted and the patient is not responding to, then definitely would suggest to pharmacological vitrolysis or like Jetria, or we can go ahead with the vitrectomy in such conditions. So that allows a single space of the vitreous cavity, and whatever pharmacological agents that we give can respond beautifully to these patients. So this is the premacular bursa which I have documented in the OCT overview. So this is anti-VEGF which was given, and this is 1 week post anti-VEGF. The response is
Excuse
very,
me, Dr. Rajesh, would you like to sum up, just wrap up?
Yes, ma'am, that's it. Just another 2 more cases. So whenever we give anti-VEGF, we think about the patient to respond beautifully, but you can see in some patients, it doesn't respond like that. It worsens. In fact, the macular ischemia increases post in these patients with central involving macular edema. The reasons unknown, but the basic reason behind is the increase in the macular ischemic nature. Diabetic papillopathy is another added features in some patients who develop papillopathy because of hypertensive NAI1 and other conditions might lead on to a sudden progression of the retinopathy and loss of vision, which doesn't correlate very well to the systemic control. So this is one of such conditions. Any of the radiation retinopathy. So a patient who has diabetic retinopathy, who has melanoma or anything, this is a patient who had been melanoma, who had been treated with brachytherapy, and that causes an additional radiation retinopathy, which might mimic like diabetic retinopathy and causes visual loss. So it may not be related to the systemic nature. So CML, that's what I was talking to you about. Collagenal vascular disease is another cause. You can see the amount of progression. The patient had presentation, and within a month later, he had developed a complete detachment. So this is immediately post-operative when the patient settled with under oil and the vision was retained. So in summary, background clinical information is very important, not just the status of HbA1c and hypertension. We need to access all his investigation, fundus images, FFA, whatever that is available with us. We should not miss anything. Even if we don't know anything, we need to keep it in, and check and keep looking back. What was the reason? And we may end up identifying a new finding with these pictures maybe later, but that might be enhancing knowledge for the future generation. Thank you.
you, Dr. Rajesh. So, because we are going too late, we'll be proceeding for the next session. It is on case presentation. It's for PG students. I'd like to just re-announce once again. It's a 6 minutes. Please stick to 6 minutes. It's a hard stop. And only one question. I will request all the judges to just ask one question to every candidate. So now the session coordinator.
No. Just one question. ऐसे रखो. Just one question.
Okay, ma'am. So the session coordinators are Dr. Sophia Ahmad, Dr. Reena Singh, Dr. Seema Kumari, Dr. Ashima Tigga, Dr. Pritish Prannoy. The esteemed judges with us, Dr. Sweta Walia, Dr. Firuz PN, Dr. Deves Kumawat, Dr. Piyush Bansal. The chairpersons with us, Dr. Sunil Kumar, Dr. Rahul Prasad, Dr. Abhishek Onkar, Dr. Poonam Singh, Dr. Vibhuti Kashyap, Dr. Tanisha Oza, Dr. Nidhi Gadkari Kashyap, and myself. So we are going ahead without any delay to our next PG students. Dr. Mayank Saran, are you available?
Yes, ma'am.
Sure, perfect. So, Dr. Mayank Saran, it's your time. Please start your screen share and please go ahead. Yeah, your time starts now.
Please start your slide, Mayank, Dr. Mayank.
I request everyone, please. Yeah, the next presentation is from Dr. Anvita Sweta Kachap. Please get ready. So, Dr. Mayank, your time starts now.
So, the slide is visible to everyone?
Yeah, it is visible. You proceed ahead.
Good morning, sir, ma'am. The topic for my presentation is surgically induced endothelial cell dysfunction and corneal decompensation. So basically in this condition, there is endothelial cell loss, which might be due to pre-existing any corneal disease like dystrophy, or it can also be surgically induced, which leads to further stromal edema or epithelial edema. So normal anatomically, the corneal endothelium is a single layer of non-regenerative polygonal cells, and most of them are hexagonal in shape. But the main point is that the influx of fluid into the stromal layer is being prevented by some like barrier, which have like barrier function of endothelium, or there are some active pump mechanism like sodium, potassium, ATPase pump, bicarbonate, and chloride transporters, and some like carbonic anhydrase enzyme, which act as a pump out mechanism, which pumps the excess fluid which is present in the stromal layer back into the ectosimmer. So the pathophysiology for this condition is that whether the patient is having any corneal dystrophy or not, but during the surgery, whenever there is an endothelial injury, it leads to the break in the that endothelial barrier, as well as there is inefficient endothelial pump, due to which the aqueous humor or the fluid it moves into the corneal layers, leading to stromal edema, and later on, if it progresses further, leads to epithelial edema. And that chronic persistent cases of those epithelial edema leads to bulla formation, which is referred as bullous keratopathy. So for the risk factors, if we are like appointing any patient for cataract surgery, we need to rule out any endothelial dystrophy, mainly Fuchs endothelial dystrophy, because there is already deficient endothelial cells, or the patient is diabetic or having raised IOP. During surgery, we need to focus on if there is we are using like high mechanical energy in phacoemulsification, or there is surgical trauma by seeing some instruments, or while placing the IOL, one of the haptics might erode or damage the endothelial layer, or the direction of the irrigating solution towards the endothelial layer, or there is some retained lens fragments in the AC. Whereas in the post-op, if there is flat AC, so it leads to the contact between the iris and the endothelial layer, or there is vitreous in the AC, raised post-op IOP, or surgeon has put an ACR, again where haptic will erode the endothelial layer, or the patient has undergone into toxic anterior segment syndrome, where due to unsterilized instruments or there's preservative-based medicine or solution are being used. So clinically, patient will come with blurring of vision or glare, which is worsened at the morning because of that non-evaporative effect during the nighttime, or the patient may complain of pain, which will be due to the ruptured bulla, in which there is exposure of the nerve fibers. Whereas in sign, we'll see corneal haze due to the corneal edema. In severe cases, there will be epithelial edema leading to bullous keratopathy. And if there is improper healing of the endothelial layer, it leads to permanent decompensation. Then that patient need to go for keratoplasty. So for the treatment part, if there is mild or moderate stromal edema is present, so we can give or advise topical hypertonic drops during the daytime and ointment at the bedtime. Topical corticosteroids can be given to control the inflammation, and if there is raised post of IOP, so we need to control that also. The patient has come with ruptured bullous, so we need to apply bandage contact lens to elevate the pain, or like we have done anterior stromal puncture of that unruptured bulla. So again, we need to apply simultaneous VCL application should be done. Whereas for the surgical part, if during the operation we have seen that there is descemet membrane detachment, so in that case we need to go for descemetopexy, where we just influx or we'll put air bubble or some other gases can be put, so that it creates a tamponade effect in the AC, and it puts the descemet membrane back in contact or in proper position with the posterior surface of the cornea. If we have doing OT of a patient who has also Fuchs endothelial dystrophy, so in those cases we also need to do endothelial keratoplasty. Along with that, there is cataract removal and IOL is being implanted. So that's a triple procedure surgery. In endothelial
1 minute
keratoplasty,
more.
in
1 minute
endothelial
more.
Yes, ma'am. In endothelial keratoplasty, we have two techniques, either DSEC or DMAC, in which DMAC has better visual outcomes due to because we are only transplanting the endothelial layer as well as the descemet layer. And if there is a severe condition of the patient and there is marked scarring or vascularization is present, then we need to go for penetrating keratoplasty. For preventive measures, it should be done during surgery. Careful handling of the instrument should be done. Use of viscoelastic material should be done. And if the patient is having pre-existing corneal disease, so we need to manage that patient accordingly. Thank you.
Thank you, Mayank. You are on time. So, judges, would you like to ask any questions to Mayank?
Hello, Dr. Mayank.
Yes, good morning.
Good morning.
Good afternoon.
So, what type of keratoplasty has the maximum rate of rejection? The penetrating one or the lamellar keratoplasty?
The penetrating one.
Why?
Because mostly, ma'am, the rejection usually starts due to that. If there is endothelial rejection, is most commonly you are responsible for that penetrating rejection.
Okay. Thank you.
Any other question from judges? Okay, we will be moving to the next candidate. Dr. Anvita Sweta, are you ready? The next one, please get ready, Dr. Pragyan Chauhan. Dr. Anvita, are you ready?
Yes, ma'am, I'm ready. Am I
Your screen? Please share your
Hello?
screen.
Yes, ma'am.
Yeah, go on.
You are audible. Please share. Your time starts now.
Dr. Anvita,